for being here for this hearing that I'm co-chairing with my colleagues, Councilmember Remy and Councilmember Green, and thank you for Councilmember White for participating as well. I want to give special acknowledgement to our city staff, our community leaders, mission critical partners, and everyone who submitted testimony for taking the time to be a part of today's discussion. This issue is deeply personal, as I know it is for many in our community. Before we dive in, I'd like to take a moment to provide some background for those who may not be as familiar with alternative crisis response and the journey that has brought us to this point. As many of you know, historically, we have used police as the response to many of our societal problems, from mental illness to substance abuse to homelessness to noise complaints to traffic speeding. You dial 911, and no matter what the issue is, you'll see a cruiser in your driveway with flashing lights. But the truth is, this approach doesn't always align with what we now know. What we know is most police calls are non-emergencies and do not involve crime in progress. What we also know is relying on police for all service calls can sometimes escalate crises that they are not trained to handle, especially in communities that have strained relationships and complicated relationships with law enforcement. I want to be clear that I support our police to be well-trained, well-funded, and robust, but I also believe that Columbus residents deserve to get the right response to the issues that they have. And I don't think that that's a controversial statement. We need to be more strategic about how we use our resources. And that is precisely why City Council launched our Reimagining Public Safety initiative. Over the last several years, we have been working to redefine how we keep ourselves safe and expanding our definition of safety from just reactive policing to proactively addressing all the determinants of safety. This has led us to make major reforms to policing in our community, like creating the Civilian Review Board, banning no-knock warrants, and investing in summer youth programs. This initiative and the tireless work of our city and community partners, we have made amazing strides in the last few years. We've introduced programs like the Right Response Unit, where a social worker helps dispatch 911 calls, or the Mobile Crisis Unit that sends a clinician out to a scene along with a police officer, or the REACT and SPARK program, teams that works on overdose and connecting people to community resources. Additionally, we've been collaborating with our partners across the city to develop community-led alternative response efforts and integrating all of these into a single cohesive system. Before I go on, I want to just take a moment to really appreciate how far the city has come in a relatively short period of time, and I mean that. Just a few years ago, we were not doing many of these things. Today, I think that we are leaders in several of the responses that we have out in the field. We went from having nothing as it relates to alternative response 6 years ago to a series of interdepartmental community-led programs that have really reshaped how we imagine safety. We could not have come this far without the tireless efforts of the CPD, the Columbus Division of Fire, the Columbus COAAA, and all of our community leaders. This work has at times been slow and challenging, but I think the early results we have seen from these programs demonstrate the incredible potential that they have. Thanks to this strong foundation, we are now ready to take the next steps of introducing a fully non-police response option to ensure our system for alternative crisis response is as comprehensive and robust as possible. This new initiative will differ from our current programs because it will not follow the co-responder model. Instead, it will focus on exclusively deploying trained social workers or behavioral health professionals for situations that do not require police involvement. I'm excited for today's discussion as we examine how our alternative response systems is evolving and explore our vision for a non-police response pilot. So if there are no comments from my colleagues, actually, are there comments from my co-chairs? Chair Remy.
Thank you, Council President. It's great to have everybody here today as we do this on an annual basis, talking about the progress our city's made with various alternative responses, such as REACT and Right Response, as well as the progress our external partners have made to move us closer to answering every call the right way every single time. But this year, I'm particularly excited to have, to note, even though we have not lost steam on alternative crisis response over the past several years, it's only accelerated. But I'm excited that we have mission critical partners here who are working with us to assess and improve upon our mission to evolve the Columbus safety infrastructure into the best, most innovative and efficient safety apparatus in the country. So their work is with us over the next year will be vital in our improvement and expansion of alternative response. And from what I've heard from their team already, I truly believe they're up to the task. And we just got done with the meeting. They were here meeting with the team earlier. I just met with them individually over the last hour, and I'm just really excited to have their partnership and work very closely as we shape this, what our responses are to every call that comes into the city. So thank you, Council President. Looking forward to the report.
Thank you so much, Chair Remy, for your leadership and collaboration. A lot of this work would not be possible without Chair Remy's leadership. So thank you. We're going to get started. And so I want to turn it over to Deputy Director Michael Holleran with Department of Safety and Assistant Commissioner Anita Clark with Health to start our city presentations.
Thank you, Council President Harden, Safety Chair Remy, Council Members Green and Weish. Thank you for today's opportunity to discuss our existing alternative response programs within the Departments of Safety and Health. Just as an overview, we have 3 goals for our existing alternative response. First, our goal is primarily to connect individuals in crisis with the right resource in the right amount of time. Second, we would like to reduce our reliance on traditional patrol and traditional EMS in our crisis response. And finally, third, to improve and innovate our responses. We're proud of the work that we've done this far, but our residents' needs are continually evolving, and we're committed to evolving our responses to meet those needs. I'm fortunate today to be joined by several of our dedicated professionals from support services, fire, police, and health. They'll provide an overview of our programs, a summary of 2024, and share some of our program successes.
President Harden, Chair Remy, Chair Green, Councilmember Weish. On behalf of Safety Director Pisciotti and Fire Chief Happ, it's my privilege to provide you an update on 2 of the city's oldest and longest running alternative response programs. The Spark and React programs are the result of almost a decade worth of effort to reimagine public safety and fire's goal to provide the right response with the right resource at the right time. The Spark and React teams are multi-agency, multi-discipline secondary response teams with primary response capabilities that operate using evidence-based best practices and protocols under the direction of Columbus Fire Medical Director Dr. Rob Lowe. The REACT program was created in an effort to combat the opiate epidemic with a pilot program in 2016. With the support of Mayor Ginther and the Safety Director's Office and assistance from several City Council members, both former and present, the REACT has grown and been formalized as an established program consisting of 4 teams of firefighter paramedics, CIT-trained CPD officers, and social workers and outreach specialists from multiple partner agencies, including Columbus Public Health, Franklin County Family and Children's First Council, FCFCFC, Southeast Healthcare, and COAAA. The tireless efforts are on display in the current slide, but aside from these impressive numbers, the most important point is the number of lives saved and the individuals positively impacted by REACT program and its team members. The most compelling evidence is the REACT Alumni Group, which represents individuals in recovery who have been assisted by the REACT team. This group now numbers in the hundreds and meets monthly to support each other and share REACT's message with the community. Several of the REACT alumni have gone on to work in SUD and mental health field, have become counselors and peers. Seeing the success of these individuals is truly what drives our team members and keeps them motivated and energized on a daily basis. The Spark program actually predates REACT. Beginning as early as 2008, the program was called the Social Service Referral Program and was a partnership between Columbus Fire and Columbus Public Health. In 2016, with the assistance of Marion Stuckey, we expanded the program with health and eventually rebranded it in early 2018 when CFD embedded its first social worker from COAAA and added a paramedic to the outreach team. The SPARK program today consists of 2 teams and a supervisor with goals to expand to 4 teams this year and 7 teams, or 1 per battalion in the future. The SPARK team specializes in working with the medically fragile, vulnerable elderly, and individuals with behavioral health and SUD, including high utilizers of EMS and 911. The team works to get to the root cause of these issues, addressing the social determinants of health, and assisted them to find the right treatment and resources. Again, the amazing efforts of these teams are on display in this current slide. The most impressive statistic is the amount of not only the ability, the quality, the improvement of quality of life of the individuals that we've assisted, but it's the amount of EMS and 911 calls the team has prevented. This not only benefits the individuals they serve, but also helps the rest of the community, allowing primary EMS and law enforcement teams to be available for time-critical life or death emergencies. With nearly a 40% reduction in calls from the highest utilizers of 911 and EMS, the success of the REACT and SPARK program provides a model template and confidence that has led to the creation of some of the other programs you will hear about shortly. Thank you, and I'll turn it over to Anita.
Good evening, President Hardin, Chair White, Shrimi, and Green. I think all of you know I'm very passionate about this work, and I guess I should introduce myself. Anita Clark, Assistant Health Commissioner with Columbus Public Health. We're very much involved with 2 of the programs that you'll hear a little bit more about, and that is our Mobile Crisis Response Team, where we embed our social workers with our police officer in responses, as well as our RRU, which is our social workers in our 911 call center. As we want to do, and it's been said, we really want to meet the needs of our community, and that's so important, the right response. And we're going to continue to see that and say that. And I think that with mission critical partners, it's going to be important to get their assessment of what we're doing great at, what we need to improve on, and where are the gaps. So I'm really looking forward to that assessment. We really appreciate the support of Mayor Ginther and the City Council as we move forward with our programming, trying to evolve, and I think you'll hear that word a lot. What we do is just not done. We need to continually look at what we're doing and what we need to improve on and expand on. So I'm looking forward to that assessment. I will now turn it over to Lieutenant Borges, who will share more details about the Mobile Crisis Response Team. Thank you.
Thank you, Anita. Is that okay? There we go. I'll introduce myself. First off, thank you, President Hardin, Chair Weiss, Chair Remy, Chair Green, for having us here. I'm Lieutenant Vorse with Columbus Police. I oversee our Mobile Crisis Response Unit. I oversee the REACT portion of, or the police portion of the REACT team and the Therapy Dog Unit. I'm also the coordinator for Franklin County Crisis Intervention Team training. I'm going to talk briefly about Mobile Crisis Response. As you see on the slides up there, we have one of our teams up there, Officer Heinzman and Zach Simmons. Like Anita said, it's a co-response model, police officer and a clinician. Currently, we have a sergeant and 5 officers, so we have six teams that go out and serve the public. All the officers have attended the 40-hour core CIT course that we coordinate. It's special. There's a lot of topics we cover. Some of the highlights are substance use disorders, signs and symptoms of mental health, youth in crisis, de-escalation, or just some of the things we touch upon. The officer clinicians meet weekly, every Wednesday. They're all together to debrief, to go over maybe some case studies of the runs they've taken this week, do some trainings, whether we have somebody come in from maybe a hostage negotiation team or some ongoing mental health training to keep them up to speed. One of the great things I love about our MCR team is we rarely, if ever, have any kinds of use of force, and they have had no use of deadly force in any way, shape, or form. It's incredible. They get out there and they do a lot of great talking. They're very good at it, and that's how they get through their shifts there. work with a lot of other resources, referrals throughout the county. We collaborate with other teams such as the Veteran VMETS, it's the Veterans Mobile Evaluation Team, and the Mobile Response and Stabilization Services, MRSS, through Nationwide Children's Hospital, which you'll hear about shortly. And right now, we run 10 a.m. to midnight, 7 days a week, 365 days a year. Thanks, sir. And a couple of stats here for you. 2024, Columbus Police, not just MCR, but Columbus Police themselves, received 21,970 mental health calls for service. And this can range from someone who's in a mental health crisis, someone who may be contemplating suicide, or any kind of run that would, any kind of disturbance, and the radio room looks for words such as someone maybe suffering from a bipolar disorder or some kind of schizophrenia. So those 21,970 mental health calls for service. Last year, I think we were right at 22,000, so the number's staying very consistent right there. During this time, a CIT officer, if it's not MCR, CIT officer was dispatched and responded to close to 16,000 of those mental health calls for service, or over 72% of the calls. MCR responded to close to 14% of them, coming in at 3,100 mental health calls for service. So that team of officers and a sergeant taking that many runs in 1 year is pretty good right there. Another stat right here, like approximately 26% of our mental health related calls for service resulted in transport to local hospital, and this has been down for the previous years. So I think this is showing we're getting out there and we're having less people go to the emergency room. We're being transported somewhere. Instead, we're providing the service to them. We're bringing the clinician and the help to the person. And in December of '24, thanks to OMAS and Anita Clark, they did some great things, and they provided 6 brand new unmarked cruisers for MCR. If you can go back that slide real quick, just to show that picture there shows the team. That's the new unmarked cruisers. They're blue cruisers. There's no lights. There's lights on them, but there's no lights on the roof. They're all embedded. There's no push bumper. There's regular license plates on there. It's a great move. They're also tinted out, so you can't, if you're in the car being transported, nobody can look in the car and see who's in there. It takes away a lot of that stigma of having a police cruiser parked in front of your house, or coming out, you call for help and an officer shows up. Well, you got officers, you can see they're in different uniforms, and we have different cruisers in order to, like I said, take away that stigma. And I think that's all I have, and I'm going to turn it over now to Irina.
Good evening. My name is Irina Yakunitsky. I'm a director with Columbus Public Health Department. I'm a clinical director for MCR and our RU team. So I just want to highlight a story, a win for us when MCR team went out. This was a caller, was someone who was on the roof threatening to jump, and a clinician and officer went out, and the person was not doing well at all. It was a freezing temperature, hasn't ate anything, haven't had water. All of it led to a lot of delusion, hallucinating, and also being fearful of first responders, the uniforms, the cars. So our clinician really quickly grabbed the hoodie and put a hoodie over to kind of really stand out from the first responder, really convince an individual that he's a social worker and here to help and figure out what's going on. Long hour of negotiation, but no force was used, and the individual safely was removed from the roof and was safely transported to OSU for mental health assistance.
Good evening, President Hardin, Chair Remy, Chair Green, Councilmember Weiss. My name is Chris Mayfield. I'm the 911 Emergency Communications Center Manager. I've been with the City of Columbus for going on 18 years now, and it's my pleasure to discuss the Right Response Unit this evening. So the Right Response Unit is a specialized resource embedded within the 911 Emergency Communications Center. The Right Response Unit is comprised of 911 emergency dispatchers and clinicians, mental health clinicians. Their goal is to connect 911 callers to the appropriate mental health, substance abuse resources that best meets their individual needs based on what's going on. So the way it works is that the caller will contact 911, or they have an option to self-select into the Right Response Unit via the non-emergency line by hitting option 3. So if they call 911, what happens is the dispatcher will vet the call, determine if the situation involves a nexus to mental health or a substance abuse disorder crisis. If they determine that it does, the dispatcher will then connect the caller with a clinician in the right response unit. The clinician will conduct an assessment. They'll attempt to stabilize, de-escalate, and then they'll refer out as needed. And also, built into the system, if needed, clinicians will work with the 911 dispatchers to respond with the appropriate public safety personnel, just in case the situation requires, public safety resources other than mental health clinicians. I just wanted to share some successes with the group. So last year, the Right Response Unit triaged 5,594 calls, which was 25% of all mental health calls that came into the 911 center that year. 40% of the calls were resolved without dispatching police, which is up from 30% last year, or in 2023. Our option 3, our self-select option from the non-emergency line, we're seeing about 1,500 calls per month of individuals self-selecting into the Right Response Unit. And then in mid-2024, we made a change to our phone tree that allows individuals to self-select and connect with 988 when the Right Response Unit is not working or unavailable. 2024, 2,690 calls were self-selected to route into 988 during the non-RRU hours.
Good evening again. Just wanted to highlight another story from RRU particularly. So our clinician gets to work with lots of community stakeholders and first responders when they're working through mental health, and this is just one of the examples. Local college called in because they received a very alarming email from a student who was suicidal. Our clinicians were able to get a hold of a student, and the situation was dire need. The student was already on the parking garage, threatening to jump, and the first responders were dispatched to really receive that boots on the ground help. But in the meantime, the RU stayed on the phone the whole time, de-escalated the individual, explained how first responders work, that everyone was on the same page, that we wanted this individual to get help from OSU ED, and the campus police were able to successfully, without any force, to transport this individual to the hospital for mental health assessment.
Council President Harden, member of council, looking into 2025, there are several things that we have on the docket at this point. Our Division of Support Services continues to hire 911 call takers and dispatchers. We think this is of critical importance since more often than not, this is our first contact with individuals who are seeking assistance. Discussions are also in process to implement a transfer of 911 mental health calls directly to 988 during the non-RRU hours, and this would be during our third shift and weekend time. We have vehicles for Spark and React that have been funded and are currently being upfitted and will be placed in service. Hopefully by spring of 2025, we'll be integrated with the Adam H. Franklin County Crisis Center as a point and a location to transport individuals to. As Lieutenant Voorhees mentioned, we have 6 unmarked vehicles that MCR has deployed and is now fully operational. And we're also in the process of upgrading our 911 software for police and fire. We think this is another critical point that'll help us both analyze the calls that are coming in and then be able to refer individuals to the correct place and get that right response. In other words, the dispatch protocols are just as important as anything else that we're looking to do. And then finally, as Anita mentioned, and as Council President Harden mentioned, we are looking forward to and we welcome the work that Mission Critical Partners will do. We are excited to have an outside look into what we're doing, the successes that we've had, and the opportunities and gaps that we have to grow and develop and evolve and move forward. Thank you for the opportunity today, and we'll take any questions that you have.
Thank you, Director, and thank you to all those who presented, and more so for the work. Like I said, I think this council is appreciative of the growth and expansion of our right response. I think that obviously we are growing and we want to make it better. That's why we brought in Mission Critical, learn how we can continue to serve our residents better. But I don't think that any objective person looking at where we were not too long ago to where we are today could really criticize that growth. I'm really excited about where we go from here, though, as we continue to look at other pilots and how we can go to a non-police response pilot as well. Talking about the growth, Director, how much does the city currently spend? If we add up all the folks that we just heard speaking, how much do we spend as a city on alternative crisis response?
Estimated for 2025 will be a little bit over $7.5 million, and that encompasses 45 positions across safety and the Department of Health.
That's great. When I dream of what a fully fleshed out, effective, right response system will look like, I think of police department. You call the police when you have a violent situation going on. Fire department, you call when you have a medical or a fire. And then when you have the other, you get this service. And so that's a big thing to set up and stand up, that other third bucket of right response. How do we currently, and this might be more of what we are studying with Mission Critical, how do all of these different alternative crises work together? I'm really big on like org charts. Like, how does this work? Like, how is the coordination? Are the different teams talking to one another? Is health and if you could pull us, the community, into behind the curtain on how does this thing work together?
Currently, each of the individual employees who are employed by the Division or the Department of Public Safety or the Department of Health would report up their respective chains of command. However, we do feel that because of the co-responder teams and the interdepartment nature of the work that we're doing, we have excellent communication. That doesn't mean to say that we're not looking forward to the opportunities that we have to hear from Mission Critical partners and to how we can better oversee and administer this program. And we do understand that that is definitely an area for growth and opportunity as we move forward.
Thank you. Last question, I think, is for Lieutenant Wirtz. When you talk about the 2024 MCR numbers being 14% of the calls, being able to serve 14% of the calls, can you tell me like what was 23? I want to show the growth or hear the growth, understand what that was before to versus what 14%, and maybe even what we can expect in terms of more of those calls being able to answer.
Well, last year we were short an officer, actually 2 officers we were short, so we were down to 3 to 4 teams we were running, so that's we hit the 14%. The year before, when we had fully staffed, and we had a retirement of a sergeant. Sorry, I forgot about the retirement of the sergeant. With him leaving, that definitely brought us down to 14. We were closer to 16 to 17% when we're fully staffed. Right now, we're posting a job. We're hopefully going to be filling the MCR officer and a new clinician and get ourselves fully staffed. So I'm looking at 2025. We're looking to hit higher numbers than we did in 2024.
Appreciate that. Because again, the goal is to have as many of our calls to be serviced, and it comes just down to resources and committing to growth in this unit. So thank you. Council members, do we have any questions for our internal team?
So we're over here, rock, paper, scissoring for who's going to go first. First of all, I just want to say how grateful I am to this entire team here. And my relationship with assault crisis work is born out from a place of passion, but it's also from a place of experience. And I'm so grateful for Captain Parrish back in the day, in the early days of the REACT team, before you had social workers, for letting this social worker just volunteer my own time regularly to go out and hit the streets and to see the growth and the love and compassion that all of you bring to this really important work that we have ahead of us it's wonderful. So I'm grateful to continue to be a part of it and have the opportunity to. I have questions, and they're really for anybody, whoever feels most, apt to answer them. You kind of talked a little bit about integration with 988 and referrals to MCR or mobile crisis. Can you talk a little bit more about what that looks like for you and timeline? I know there are some challenges at the state and federal level with integration, but
Be happy to answer that, Chair Green. As far as integrating 988, we've already done that with our self-select on the phone tree. So that's been successful, and we met this month internally to talk about what that would look like for the non-emergency line. And I think it's going to be relatively simple. We've been in touch with Adam H., and they are supportive of this move, and we have to do some really just some process flows in the ECC for the next step. That's kind of phase one is with the 4545 line, pound 3. And then when we go to the third shift in weekends, we have a little bit more work to do, but we're hoping that we could do it, and I think it's realistic to think that we could do it. I'm going to throw it out there by at least second quarter of this year.
that's
Can I
awesome.
challenge all of us here to do that? I think that's realistic.
Wonderful. Can you also talk a little bit about how these programs are collaborating with our other crisis providers? I'm thinking our MRSS providers that are supporting our youth populations, our net care. I know the goal will be, and certainly there will be collaboration with the Future Crisis Center, but are we effectively kind of integrating and kind of being able to maximize all of the different parts of this crisis system, or is there opportunity there?
That's a great question, and yes, the answer is yes. Through the Adam H. Board, there's several work groups that meet regularly. One is the 911 and 988 providers that have a work group and meet. That's NetCare, North Central, the ECC, RRU. We share stats. We've worked through some MOUs and information sharing. And then Adam H. also has the Community Crisis Response Steering Committee, which is represented by many of the folks in the room tonight, along with the community providers. And all of that built around our efforts and input in the design of the new crisis center, access for first responders, for law enforcement. So the collaboration in the community is outstanding, and I think that's one thing that really makes Columbus unique, is everyone realizes there's a lot of work to do, and no one's trying to do it all, and we've really developed those relationships and partnerships.
Yeah. Well, I think also too, we're in the middle of a behavioral health workforce crisis too. So when you're talking about trying to find people to do this big and important work, it's not as easy, I think. So that collaboration helps fill those gaps too. And then I think the last question that I have for now is, as we're looking at scaling these programs, what strategy, I know, Cap, you and I have gone back and forth banging our head on the wall a little bit about this back in the day, but like, what strategies are we looking at for blending and braiding funding that's available, like billing for crisis services? I know both CPH and CFD, bill and get reimbursed for certain parts of your continuum of care that you're engaged in. And I think finding additional sustainable revenue is important for allowing us to grow the program. Certainly, we're kind of seeding it now. But how are we thinking about that as we're looking at opportunities for growth?
Thank you, Councilmember Green, for that question. That's critically important because sustainable funding is essential for us to continue our operations at the level that we want to. One of the important things that we think we'll learn from our consultants' work is what our steps moving forward are, and then how to design our programs in such a way, or adjust the programs that already exist in such a way as to maximize those revenue generating opportunities. So I can't answer specifically that we'll take step 1, 2, and 3 right now, but our goal is, as this work continues for mission critical partners and as we evolve this year, that will be a priority for us, is sustainable revenue and financing of our programs.
Actually, I do have one other question too. And again, this might be mission critical, something you're looking at, but very related to scale, to being able to scale the program. Thinking about workforce challenges, have we considered, again, as a social worker, I think a lot of times people think that social work is sort of the opposite of police or emergency response. I very much view us in a lot of ways as two sides of the same coin. It's just a different type of response, right? And so thinking about the workforce challenges that we're up against, also clearly there's a need in the community based on the data that we're seeing, and we probably have even more that we could be doing if we, as we're learning and continuing to grow. Have we thought through opportunities for training programs? I know that there are some really great associate's degrees, for example, through Columbus State Community College that focus on behavioral health and crisis response. And have we thought through alternate pathways to be able to grow this workforce here locally that would meet our needs? Sort of similar, I mean, it wouldn't have to be like a police academy or a fire academy, but I think there's opportunity for integration there, where if we can't find a workforce, maybe we could help support it and grow it ourselves, especially something, with the Columbus Promise program, right, where we're helping assist people in achieving those associate's degrees. If there's, maybe look at how could we build a career pathway? Are we thinking through that, or?
I have a little bit of insight into that. I know that at one point in time, the Community Shelter Board was working on a project with Columbus State to develop specific curriculum for crisis response. And I'm not sure where that stands right now, but I think to Director Halloran's point, the funding is important in developing and recognizing efficiencies within this response, which is all critical at the point of entry, so we're not duplicating efforts, which will also help expand our workforce with the limited number of workforce with the skill set. So there are some groups working on kind of specific crisis response curriculum, certifications. I know OMOS was working on that with their crisis response project. So it's being looked at, but nothing's been formalized to this point that I'm aware of, but definitely on our radar.
Thank you. And thank you, Councilmember. I think that's, even just your line of questioning shows the importance of having a social worker on council. Like, seriously, we appreciate it. Next up, we're going to have presentations from some of our external partners that round out and make up our current alt crisis responses. I'm going to first ask Sue Valillo, VP of Clinical Services at Adam H. Board, Franklin County, to come and present. Welcome back, Sue.
So good evening, Council President Hardin and members of Columbus City Council. I'm Sue Valillo, Vice President of Clinical Services for the Alcohol, Drug, and Mental Health Board of Franklin County, also known as Adam H. On behalf of Adam H. CEO Erica Clark-Jones, thank you for inviting us here and for your continued partnership. Adam H. provides a pathway to health and healing for individuals and families in Franklin County seeking resources for addiction and mental health services through a network of more than 30 nonprofit agencies. Although we're here tonight to discuss alternative crisis response, and we'll focus on that work, Adam H. views crisis care as a continuum of services and interventions that include someone to call, someone to come, and somewhere to go. And over the past several years, Adam H. and its partners, including law enforcement across the county and our local hospitals, have been focused on strengthening the entire crisis care continuum. The 988 Suicide and Crisis Lifeline, which we refer to as Someone to Call, was implemented nationally in July of 2022. This easy-to-remember three-digit number links people experiencing a behavioral health crisis to an immediate response. Locally, these calls are responded to by Adam H. service providers, North Central Mental Health, and NetCare. Each organization has an extensive history operating crisis phone lines. And as previously shared, 988 and 911 are collaborating to ensure interoperability between the lines in Columbus and across Franklin County. Alternative response, or someone to come, occurs when the crisis requires an in-person response. Adam H. supports programs that send behavioral health professionals to the person in need to stabilize them and keep them safely in the community. Adam H. currently partners with NetCare to offer community mobile teams, including a clinician and a peer supporter, dispatched through 988. These teams will soon operate 24 hours a day, providing intervention and support, linkage to needed community resources, and follow-up care. This evidence-informed service provides a non-police response to a behavioral health crisis. NetCare has also continued to provide additional mobile teams through outreach workers who transport publicly inebriated individuals to Mary Haven's Engagement Center, community crisis response teams who provide community intervention during large-scale emergencies, and probate pre-screeners who can conduct an assessment and initiate the probate process for involuntary psychiatric hospitalization. Adam H. also supports Southeast Healthcare's REACT team, who provides immediate outreach response to opioid overdose and opioid use crisis situations. REACT refers patients to substance use treatment, connects them to crisis care, and provides follow-up support. REACT responds directly to emergency departments and EMS dispatch requests throughout Franklin County. For the past 2 years, Adam H. has taken the lead in convening quarterly meetings with crisis call centers and mobile response teams operating in Columbus to ensure that quality behavioral health services are available when people need it the most. Participating in the meetings include all of the wonderful people behind me, Columbus Police Department, Columbus Public Health, Columbus Public Safety, Columbus Fire Department, North Central Mental Health, NetCare, the VA Veterans Administration of Central Ohio, Nationwide Children's Hospital, and the Center for Family Safety and Healing, all working together to coordinate services and create a robust system. We are grateful also to have representatives from the Ohio Department of Mental Health and Addiction Services and Councilmember Green's staff participate in our meetings. Lastly, I cannot conclude without expressing our gratitude for the incredible partnership with the City of Columbus, Columbus City Council, the Franklin County Commissioners, and our local hospitals for the support in constructing the Franklin County Crisis Care Center, which will be our community's someplace to go. It's set to open its doors before summer this year, and this facility will be the 24/7, no wrong door approach for adults experiencing a mental health or addiction-related crisis in Franklin County. Thank you, Council President Hardin, for the opportunity for Adam H. to speak tonight. We look forward to working with mission-critical partners and sharing more about the current and future initiatives happening in this space. And I'm happy to answer any questions at this time.
Thank you so much, Sue. Do any of my colleagues have any questions for Adam H? I would just say, I mean, it seems like maybe a small thing, but that coordination that you do with having all the providers together is huge. I get, with all of crisis, I get hung up on the process, like how are we putting this, making this thing operate as a functioning entity, and a part of it is just communication. And so I really am appreciative of the role that Adam H is playing there. Certainly, we're excited about opening the center and look forward to that this summer. Any questions?
I just want to say, I don't have a question, but I just want to recognize Sue, and I want to thank the Adam board. You know, when 988 rolled out this past year, there was no money assigned to it in the budget. And the Franklin County Adam board stepped up and said, this is something that we are going to do. This is a value of ours. Addressing the needs of people that are in crisis is the most important thing we should be doing. And so I want to thank you so much for you and for the Adam board's work and commitment to that.
Thank you both for your comments and the tremendous partnership of the people in this room. We really appreciate all of you.
Thank you. Next up, we have Jessica Michael from Children's Hospital MRSS program.
Good evening. Thank you, Council President Harden. Thank you, Chairs Green and Ramey, and thank you, Councilmember Weish. My name is Jessica Michael. I am currently the clinical manager of our Mobile Response and Stabilization Services Department at Nationwide Children's, as well as our telecrisis program. And as we're here talking about alternative crisis response, I'm really appreciative of the opportunity to talk about our MRSS program, as we're in the same vein and work a lot with the folks in this room. So just want to share with you a little bit of why MRSS was born for us at Nationwide Children's. A majority of the youth and patients that are coming into the psychiatric crisis department, which is our emergency department for psychiatric crises, and then a majority of folks that are calling into our Franklin County Youth Psychiatric Crisis Line, they are actually able to maintain safety in the community following a crisis, and they're not recommended to come in to the hospital to receive a higher level of care. So when we kind of mush those two things together, we realize, you know what, we can do a lot in the community with meeting crises where they're at, going out to patients and families to help them in that moment. And MRSS was kind of born to help fill that gap. So if you haven't heard of MRSS, it's a state initiative under Ohio RISE. It is a program that responds to immediate behavioral health services at home or another safe community location. We're able to see folks under age 21 who are experiencing a significant behavioral health crisis or emotional disturbance or distress. And we utilize a family-defined crisis model, meaning that whatever the family deems as their crisis in that moment is a crisis to us. And you can see there that the goals of the MRSS programs around the state are really to decrease unnecessary emergency department visits, decrease youth's involvement with child welfare, juvenile justice systems, decrease out-of-home placements, and then also decrease the need for police responses to situations that may not warrant a police response, and maybe we can put a social worker or clinician into that community location. We also have a no wrong door approach, so families are able to call the MRSS state line that is run from an entity up north, and they can farm it out to the appropriate county, or families can contact our Nationwide Children's Hospital crisis line in order to dispatch the MRSS team. And this is kind of a simplified version of our model. It starts with that screening and triage process through our telecrisis program. They're identifying the location of the crisis, they're identifying any safety concerns, the presenting concerns, and then they're able to move to dispatch MRSS out to the community. Our goal as a model is to respond to that crisis within 60 minutes, but we also have the flexibility to kind of book crises 48 hours out, which gives us some really nice wiggle room with families if they're anticipating a crisis or a stressor, next day or 2 days from then, we can get them on the books. We're able to provide de-escalation, risk assessment, safety planning, and we're able to really get into the homes and do some of the safety proofing alongside the family, which is really helpful. Those initial mobile responses are typically 2 of our staff members. And then if it warrants it, we can move into the stabilization phase. That can last up to 6 weeks. On average, we are looking at about 2 weeks in that phase with most of our families. We are getting folks connected with resources, getting them linked up, providing a lot of that skill building, and then transitioning them on to other services. And those appointments are typically one responder. This is our current MRSS crew over at Nationwide Children's Hospital. We actually went live in fall of '22. We are the Franklin County provider currently for this model, and we are responding Monday through Friday, 8 to 8. And our team consists of licensed clinicians, qualified behavioral health specialists, parent-peer support specialists, which is a really unique role that we have. They have lived experience going through a lot of the things that our families have gone through, and they're able to work with the caregivers really closely, which is great. We have a care coordinator, and then, of course, our leadership team. And you can see just some stats here that you might find of interest. You can see that we are responding to a lot of teenagers, kind of in that 12 to 16 range, certainly some younger kids, and then some of the young adults up to age 20. We've served about 1,300 unique patients and families since we went live, but we've responded to over 2,000 crises in that time. So some folks are needing us, certainly more than once. A majority of our responses are occurring at home, followed by school responses, and then suicidality remains as our top referral reason, followed by that aggression and outburst. And then we're proud of this stat. We have only utilized law enforcement support about 4% of the time in the field. And with a lot of the folks in this room, they've partnered with us to help support us in those moments where we might need them. Just some important notes, we're not a replacement service, we're really a supplement to other linkages that families might have. We're not able to physically transport our patients to the hospital or anywhere else, and we also don't utilize physical interventions in the community. If a situation is unsafe for MRSS, our telecrisis program can handle a lot of crises over the phone, and they do, and they can do assessments and safety planning and all of those good things. And then certainly if a family is needing emergency services, we can loop in those services as well and support them. This is our public-facing flyer and a QR code that goes along with that, so feel free to spread the word about us for Franklin County and the rest of the state. And then also at the bottom there, if you would like to know more about the model or see what other county providers there are for MRSS, you can go to that website. Okay, thank you very much. Any questions from anybody?
Thank you so much. Just to clarify, then I think you operate 9 to 5 Monday through
Monday through Friday, 8A to 8P.
8 to 8.
Yep, and that's a recent switch per some state, the state decided to have that push go 8 to 8. We were 9 to 9, and then we've kind of shifted up based on some of that data. We get a lot of those referrals in the morning from kids that are having some school avoidance and things.
That's awesome. Okay, thank you so much. Thank you.
Thank you, appreciate it.
Our last partner that is with us is Heather Stumpf, Director of Community-Based Services at NetCare. Welcome.
Good evening. Thank you to President Hardin and the council for allowing me to be here today. My name is Heather Stumpf. I'm the Director of Community-Based Services at NetCare. I have been working in Central Ohio in the field of social work and behavioral health for 25 years, and I am a licensed independent social worker. I just want to speak a little bit about what NetCare is currently offering for services to kind of piggyback off what Sue said, and then more specifically, the crisis services that we're doing in our mobile team. So NetCare has been a behavioral health nonprofit provider in Columbus for 52 years. 30 of those years have been dedicated to providing specialized behavioral health services to the residents of Franklin County. We currently provide our civilian mobile response team, which I will speak to in more detail, outpatient behavioral health services, 988 services at local, state, and national levels, our own legacy crisis line that we've had for decades, 2 residential crisis programs. We run the homeless hotline for folks to get shelter in our community with a contract with the Shelter Board. We have probate pre-screening services for folks, for our staff to go out and assess if somebody meets their criteria for involuntary assessment and possibly psychiatric services through the probate court. And last but not least, our row services. If you've seen our vans with our logo, we are picking up folks who have called us who are currently intoxicated and unhoused and take them to Maryhaven for shelter. So you can imagine these last couple of weeks, they've been pretty busy. In addition, law enforcement uses our mobile team clinicians in a program called CCR, where we go on scene to tragedies to assist our first responders and interacting and providing information and support to those immediately impacted by those tragedies. That program has also been around for decades, and I've been lucky enough to go out on 2 of those runs myself just this week. We've been providing mobile crisis services for about 8 years. In 2023, we relaunched as a civilian mobile crisis team known as CMT. In this model, a licensed clinician and a certified peer support recovery specialist who has lived experience in behavioral health or substance use recovery respond to behavioral health crises in our community. We currently have 7 teams, 7 of those pairs, and we work 8 a.m. to 10 p.m., 7 days a week, 365 days a year. In the next month or so, we will be launching the first 24-hour civilian mobile crisis service in Franklin County. Netcare is also part of the Alternative Mobile Services Association, which is a national association that shares best practices and innovation and allows for collaboration among organizations throughout our country. We're in regular communication and coordination with other mobile teams, as Sue and the others have already previously spoken. We regularly coordinate with our 988 services to get those callers connected to our mobile services if they are in need for an in-person response, if it cannot be resolved over the phone. As 911 works to transition some calls to 988, that will be a way that folks will have increased access to have folks come to them where they are. That could be their home, the library, gas stations, wherever they are and is a safe place that they would like us to meet with them. So Netcare will be receiving an increase of calls as the system slowly shifts. Once we're called out and arrive on scene, we do a clinical assessment to determine the best course of action. And we share that recommendation with the individual and also get their input as well. Sometimes people have concerns about pets or work, or, we help problem solve and come up with a plan for them. If they do need a higher level of care, such as a hospital, we do have unmarked cars. We're able to transport them if they're willing. All of our services are voluntary. As an additional option, Netcare has a crisis stabilization unit. So if somebody maybe does not need a hospital, we have a 7-day program where folks can come voluntarily to see a psychiatrist, which is a very highly sought after service, and participate in individual and group sessions to learn more about the things they're experiencing and coping skills. Another outcome of a mobile run could simply be that they receive support resources and they're able to be maintained in the community. One unique thing about us, similar to MRSS, is that we are able to do follow-up for 14 days. So once it's not just assessing what do they need, we're actually able to give them phone calls with their consent, or follow-up, come back out. I just want to give just one scenario about, there's many I could give. But let's say there's a resident in our community who has a severe and persistent mental illness, and the family calls us directly or can come through 988 currently, and is concerned about their symptoms that we say are breaking through. Maybe they're in treatment, maybe they have medication, but their symptoms are coming back and they're becoming concerned. We've been in this landscape again since 1972. We have good relationships with all the agencies. We can coordinate with those agencies to move up their appointment. Let's say they don't need a hospital, but they're headed that way. We can move up their appointment. We talk to the psychiatrist. Maybe their injection is due on Friday. Maybe we move it up to Wednesday. And we save that person going to that hospital using that resource when really that might not be, what is indicated. Again, and you've heard this before, the crisis is defined by the client. We could have someone who maybe is elderly and someone has passed away. We will go out, we'll offer support, we'll provide education, and we'll get them connected. And then we will follow them until they actually, we've gone to support groups with people, we've taken them to doctor's appointments during that 14 days just to get them to where they need to go. And I'm getting there to the end. Thank you for your time. If we have folks who are experiencing suicidal thoughts, we do a thorough assessment, history, and we determine their level of risk. At times, it's absolutely necessary that they do go to a higher level of care for their safety and for others. There are other times where suicidal thoughts can be managed by a solid safety plan, support, and a linkage. I think the word before was connection, right? Connection, innovation. Each run is different, and we have a consulting chain with supervisors, psychiatrists, medical folks as needed to help us problem solve what could be helpful. We are field instructors for Ohio State University and regularly take interns, speaking to training the workforce for the future, going into classrooms and talking about crisis services and letting folks know that is an area where they can get into with their social work degree. Finally, I'd just like to say thank you to the Adam Board for their support and innovation in supporting us over the years, and to the committee, and for everyone who's trying to meet all the needs that are out there in our community, and to try to do it in a way that's integrated that's efficient, and really just reaches those folks that need us. So again, thank you so much. I really appreciate the opportunity tonight. Thank you.
Thank you so much, Heather. Heather, I have a question. You said something that really piqued
Yeah.
one, you said that, I think I heard that you said it in the next month, you will be able,
Month or two, yes.
moving to a 24-hour
Yes.
response. That's a really big deal. But two, kind of on that last point that you were making, that, thanking everyone for that integrated model. How well do we work together right now? How plugged, because when someone's in crises, they can't look for the number to call. They can't pick which one to go to. Our back of house coordination has to be flawless and seamless
Right.
to make it easy when someone is experiencing crisis to get what they need. Again, I think that we have to applaud where we are because of where we came from in a short period of time, but also not take our eye off the mark that we probably aren't there yet,
Correct.
serving that need for a person, a family in crises.
Yeah. I think there's a lot of doors right now, and I think we have a lot of different services, which is a strength because we have a lot of different folks who are specializing in different populations. I think the Adam Board has done a great job of bringing those folks to the table and kind of streamlining that. And as you know, systems can be kind of slow to change. But I think, working with 911, what calls can go to 988, that kind of helps, folks get to the right place that way. And I think too, there's always going to be people who specialize in different things. So for example, if somebody has a gun, in their home, or we know they have firearms or history of aggression, that would be more of an MCR run than
For
kind of,
sure.
our run. So I don't have a great answer. I think we're headed in the right direction. And you're right, it's kind of like the behind the scenes coordination of where do folks go first? And then from there, how do we streamline and kind of specialize
Yeah.
out? And we're working on it.
Thank you.
You're welcome. Any other questions I could answer?
Thank you so much. We really do appreciate
Okay,
the
I
partnership.
appreciate the time. Thank you.
Next, we go to a really exciting part of our presentation. As Chair Remy spoke about in his introduction earlier today, there was a large meeting, or a big meeting with Mission Critical Partners, our partner that is coming in and assessing where we are as a city with alternative crisis response. We don't want to just pat ourselves on the back and say we're doing well. We need to have this evaluated, but also specifically to help us look at non-police responses around the country to see how we can pilot that as well. I believe that this is the time, as we are piloting all the other good types of responses, to also work towards a non-police response pilot as well. So with that, I'm going to turn it over to Bonnie Manny. Bonnie, welcome to council.
Well, I have to say that even though we have really done a lot of research and reading, I feel like we just had a crash course in everything alternative crisis response in the city of Columbus. And thank you so much for that. And thank you to this team here. We have been very welcomed. We appreciate so much the opportunity that you are entrusting with us on this very important initiative. But again, to applaud you right now on everything that you've done, where you have come, is no small feat, and it has been a great collaborative effort. So my name is Bonnie Maney. I am the operations manager with Mission Critical Partners and have the pleasure of being the senior advisor on this project. MCP, for those that do not know who we are these industry leaders. We are professional and managed services. We focus on the public sector, primarily in the public safety and justice space. We are a nationwide firm. We do cross all 50 states. Within the entire ecosystem that we work within, we have over 200 subject matter experts. We average over 25 years of experience each. I'm very happy to say that the team that we have on this project is just an example of that. On this project, every one of us come from the public safety space. We have been either under the headset or we have been out in the field in some way, whether it be also in armed services or serving our communities. We know that we are looking at a significant number of requests that traditionally may not require a traditional public safety response, and that the goal here is to see what other opportunities there are in the community and within the government services that can respond, whether that be an unarmed response or perhaps some other governmental service that could be incorporated. We do look at this not only as alternative crisis response, but also response alternatives in general for things that may not actually fall under the true public safety umbrella. And so the results we're looking for, of course, we want that more appropriate response that is faster, that does have higher community engagement. We're looking, of course, to decrease the risk to the field responders, and of course want to save more lives and have safer communities. So as it's been mentioned, why are we here? And we are really looking to engage with all of you, all of the stakeholders, of course, the current alternative response programs. We want to look toward recommendations for future growth, administration of non-traditional public safety response activities. And we really want to look at 3 key areas, but it is not limited to these 3, of course. There is talk about, we've heard tonight, about that collaboration, that back of the house. How is that working? Is there other opportunities there to make it more cohesive, more efficient? We want to look at, of course, that unarmed response. And are there opportunities for standing up temporary committees that could help with that, that more cohesive and communication to make it even more efficient? So we look at this, and I mentioned the ecosystem earlier, and we do look at it from an ever-expanding, ever-evolving emergency communications ecosystem. This graphic in particular is just a snapshot of what that can look like. And back in the day, it used to be very simple. You would use a call box or a telephone, and you would call to a police precinct or a fire area, and you would go into a control room, and you would send police, fire, or EMS. Very basic. It's not that anymore. We have IoT devices and smart cities and all of these different devices that can let people know that they may or may not have an emergency, or they have a need, at least in some way. And so the ecosystem has evolved to have a 4th arm or a 4th pillar within the community that serves a purpose, and that is what we have up here depicted as those helping hands. This ecosystem, this graphic, is going to evolve here within Mission Critical Partners very shortly, because what we know is missing is the actually some sort of communication from community directly to those helping hands without maybe necessarily having to go through a 911 center or some sort of entity like that. So this will be evolving as well. So you want to know about the project. So the project itself, we've broken down into 4 phases. We're really, this morning you mentioned a large meeting. That was our project initiation kickoff. Well, we've actually been doing a lot of work up until this point, but to have a formal kickoff, that happened this morning. And then we're going to, from here, we're going to make sure that we set up very bi-weekly progress calls so that we have constant contact, with the key core team. Today really kicked off a really hearty part of our data gathering part. We've asked for a lot of data already that we're having uploaded and that type of thing. But this is our on-site schedule. And I'm going to show you a little bit of what that looks like here in a little bit. From that data gathering and discovery, we're going to go into an analysis phase. We're going to go back. We're really going to dive into all the numbers, also the qualitative information. And that's what really we're looking at getting while we're here on site. And then that's going to result into a draft and then a final report. We explained this morning during the kickoff that that is actually a very detailed and very structured review process, that we want to make sure that what we provide to you is not only factual, but that it is practical and realistic. We do not want our deliverables to you to go into a drawer and not be seen again. It needs to be something that is practical, it is actionable, and is in many ways reasonable as far as an approach. It's not necessarily going from 0 to 100, but if we can have a commitment to gradual progress that takes you from 0 to 10, 10 to 20. The timeline on this, initially this project I believe was supposed to take flight in August, but there was a bit of a delay. I understand, getting contracts and all of that settled takes a little bit of time. So we did kick this off initially in August of last year, and we are anticipating final report and close out July and August of this year. So I mentioned about data collection. We do look at qualitative and quantitative. There's a lot of materials that we already know exist, existing reports, the Reimagining Public Safety report, those types of things that we're already taking a look at. This week is really about interviews, focus groups, town halls, listening sessions. And Jenna, the project manager, she has been diligently shifting things around as well. We heard several of you tonight that we want to make sure that we get on that list while we are here, or make sure that we are taking care of that even after we depart next week, in whether that be virtual. We may have some surveys. We want to really get into community engagement. When we were with Councilman Remy earlier, we were talking about how we might be able to do some of that more community engagement with the council staff. We do want to make sure, and we've been learning this a lot already, terminology alignment in this project is huge, right? You call it runs. You have certain terminology for certain things. We're very used to listening to what they call it around the country, but we want to make sure that when this report is done, it is speaking to you in your jargon, your language, what's Columbus. And so, we're going to be collecting data. We're going to be looking through it across all of these phases. This is just a sample of the outreach strategy, looking at government officials, EMS and fire, law enforcement, of course, communications, your communities, your collectives, and all of your alternative programs. We are wanting to meet with all of them, and you can see here down the left-hand side what some of that looks like as far as timeframes. We are encouraging everybody to understand that this is not a one and done when we have these meetings and these interviews, and encouraging anybody that may want to reach out to us and have a discussion that may not be maybe comfortable doing it into a focus group, that we are available. We are your partners in this. So within that analysis, we're going to be looking at the challenges and the barriers. We're talking a lot about that, or we want to talk a lot about that with the existing programs, and what approaches could be possible in the future. We also want to talk about efficiencies. What does that look like? I've heard a lot about the no wrong door, and we really understand that approach. But on the left, you can see here an example of what it's a very common current state that we see, and that there are so many doors that folks don't know where to go. Or once they go into that door, it's we call it a spaghetti bowl, affectionately, of how to get where they need to go. And that can be very, very challenging and frustrating for people, especially when they are in crisis. So the idea is how can we find efficiencies and streamline some of those processes and those workflows. We also then want to go and take a look at this from a risk reduction perspective. How are calls being allocated? How are the call types and 10 codes, what are the criteria for when they go to 988 or RRU or MCR or any of those other programs? We want to make sure that we weigh the risks so that we can reduce that risk exposure. And within this too, we want to look at how have things been happening in other places across the country so we can develop a blueprint for Columbus. And then, of course, we want to look at this from the administrative perspective as well. And that is and especially, very importantly, that a one size does not fit all. It is great to look and see what has been happening around the country. And I can very confidently at this point also tell you all that with the matrix and layers of programs that you have already had, which again, you've demonstrated tonight and that some of these are going back to pilots in 2018, you are definitely ahead of the curve. So that does not, again, mean, though, that there is not room for improvement, collaboration, and how can that perhaps, from an administrative perspective, are there opportunities to centralize what so far, from what we're seeing, is quite a decentralized type of approach? And are there efficiencies, and how can that be, how can that work perhaps better? And so ultimately, when that, taking all of the data collection and the analysis, and when we get to that phase 4, we want to be able to put together an alternative response planning strategy for you. And what that takes, what form that is going to take at this point, we do not know. We do not come in with any preconceived notions. We really are looking to a lot of fact-finding, and we want to make sure that the quantitative data and the qualitative data, somewhere where they come together, that it does be able to provide that practical, reasonable response, alternative response planning strategy that you will be able to apply and make what you're doing here in Columbus even more productive and useful for your constituents. And with that, I would like to say again, on behalf of Mission Critical Partners, we really do appreciate the trust that you have put upon us, and we look forward to working more with each and every one of you. And thank you, and we'll take any questions that you may have.
Thank you so much for being here and for your presentation, for the work that you're doing with us. Bonnie, we really do appreciate it. When we talk about the 3 focus areas that we contracted with Mission Critical to look at, one, looking at our current systems, how we are operating, how do we integrate better, how do we do the behind the scenes, how do we get back to that closer one-door model, one being very important. Second, exploring how we create a unarmed law enforcement model being the second key component of this contract. But thirdly, that's where my question is, around setting up a community advisory committee to help advise. Can you talk about that third arm? How important is that when you, from your past work and other communities that have highly effective alternative crisis, how like what is the importance of that work, and how do you look to advise us in that engagement?
Well, I think that falls under the administrative kind of part of that, that third area, in that it would have to be something that is very collaborative, representative of the communities that are being served and the types of challenges that they're facing. I think it falls, as far as the importance of it, it depends on the community. Some may really need to have that. It really depends on historically, how have they gotten to the place that they're at. Even issues like, is the community under consent decree or some sort of agreement with DOJ, which I understand we are not in that situation here. That can open up different opportunities that maybe other communities do not have. And in that regard, doing something voluntarily and bringing those folks to the table can be very powerful in creating that buy-in and making sure that around that the appropriate care and consideration is given to those folks and their input, because it can also be very challenging when you take all of that information in and then decide to go in a different direction, which can then break trust, right? So it is, again, a very sensitive balance, but the fact that you would want to be doing something like this voluntarily, it can really go a long way in helping the community further support what you're trying to achieve.
Thank you. I just think it's really important, especially for communities that have had challenging histories with enforcement and that need this the most, to be able to be a part of building something. A lot of the work that we have done has been because we've had dedicated activists pushing the city in this direction, but also I think that, and I won't speak for our community activists and leaders, but I think every time we allow for folks to see what we are already doing, I don't think that we do a good enough job telling our story on our own. I think that there are spaces and work that is being done. There are ideologies and engagement across all of the partners and even internal to the city that believe in this and are closer to where our community is than they know. But because we don't put proximity with them, it allows for more mistrust and doubt. And so I just really think that I just wanted to highlight that to me as being equally as important as the first two components of the work that you're doing. Do any of my colleagues have questions or comments? Chair? No, please.
Hi, Bonnie. Looking forward to meeting with you tomorrow, I believe, so we can dig into the details here. But I did want to ask a question. So I asked a question earlier about opportunities to blend and braid funding. I know here in Ohio, we have been waiting for the last year for these crisis rules that will guide practice around mobile crisis response outside of the kid space, which we already have. I think now more than ever, as we're facing what I know Council President has talked about as the tightest budget that we've seen since your time on council, and looking at the future for how we're planning and preparing, I know how our ability to really scale this program to the level that this community needs and deserves so that we can, follow through on our commitment to make sure that every call gets the right response every time. Our ability to do that is directly linked with our ability to pull in every additional available dollar that might be available through Medicaid reimbursements or whatnot. And our ability to do that is contingent upon us meeting those requirements that the state are going to set out. And while we don't have those in front of us, I don't think you have to look very far to see, I imagine with the new MRSS rules just recently being filed, it'll probably mirror that very closely. So what work are we doing, to communicate with the state, as we're developing this program to see if there's any additional insight that they can provide to us based on what we can anticipate this year coming out with those crisis rules? And how much are we looking at the current crisis rules for the Mobile Response and Stabilization Service as a guide to guide us as we are designing and implementing a program?
Well, I think, as you mentioned, that funding is very important overall in making any of this happen. And so that will be information that we will dig into. Of course, we want to make sure that we talk to the partners that, are, intimately familiar with that and living that every day. We are just at the very beginnings of our research, right? So I know that the team has been taking notes diligently back there on all the different things we're going to want to make sure we ask and dig into and add to our list and things like that. So I think it would be premature to kind of talk about what any of those particulars are, but yes, funding, rules, regulations, things that could be considered constraints to what you want to accomplish is something where you're going to definitely dig into and look at. Now, with that, I would also mention that when we are starting to come up with our set of recommendations, that we would be looking to find things too that may be very low cost or, be able to more easily accomplish while you're trying to tackle the larger, more complex, perhaps more expensive types of recommendations as part of that strategy. Okay.
Thank you, Council President. And Bonnie, thank you for being here and for the presentation. I think it's just so vitally important that we have third-party assessment and evaluation to ensure that what we are standing up is working and working well for the community. One question I did want to ask, you mentioned kind of community engagement and engaging the community in focus groups or town halls. Has that list of community stakeholders finalized, or what has been best practice that you've utilized in
Well, it hasn't been finalized.
Gotcha.
And as we find more, we want to continue to engage in them, and we do want to kind of build out that strategy. I know we do have a meeting already on the calendar with the collective, the Columbus Collective. And so that's going to be able to be a start of that. But we know that, the city does have a community engagement, team that we want to engage and start finding out are there others. Now, in other engagements that we've had, We have sat down and conducted listening sessions with a variety of communities from, all walks of life and with lived experience, whether those be from the BIPOC community, from the domestic abuse survivors, substance abuse survivors, all of the, we will sit down with those communities and have those discussions. And that's what we've done in other places, and we hope to do that here as well. We are riding along and doing sit-alongs, as we would call it, with RRU, but we're going to be going out and riding along with MCR this weekend and other units as well. I don't know the exact schedule, but we're going to be not just sitting and listening and talking. We're going to be out riding, observing as well.
No, I appreciate that.
Yeah.
I think sometimes there's always this feeling that, well, we can just communicate with those who are in the city and in City Hall, but, and think we're truly hearing what the community needs. But honestly, it's going to the community and getting their insights to help improve programming. So I appreciate you guys are already thinking ahead to who else you can kind of engage external to the city to truly understand where the gaps are. So appreciate it.
Thank you. Any other questions?
I think that is it, but thank you so much. We look forward to, this is not the end of our engagement and questions and conversations. It's more so the beginning. So we look forward to working with you over the next several months, and certainly look forward to the report to help us get better. Thank you.
Thank you, President Hardin.
Thank you, Bonnie. Now we might be at the most important part of our hearing, or certainly an important part of the hearing, is hearing from our community. Just would ask that we keep our comments to 3 minutes, and just, if you're representing any organization, would you let us know who you're representing? The first speaker to come before council is Helen Ann Sweeney. Helen, welcome to council.
Good evening, President Hardin, council members Remy, Green, and Weish. My name is Helen Ann Sweeney of BRED, which is a member of the Columbus Safety Collective. Our comments focus on policy questions posed by the Division of Public Safety in the RFP for an alternative response plan. This system would handle nonviolent crises involving, but not limited to, behavioral health, food insecurity, and wellness checks. BRED raises the following concerns about these policy questions. 1, the RFP is not explicit as to whether the non-police crisis responders are first responders. Non-police crisis responders must be first responders. Many non-police crises have the same urgency as a crisis involving violence, fire, or a medical emergency. When ill-equipped, poorly trained first responders are sent to handle non-police crises, avoidable bad outcomes such as handcuffing and shootings can occur. 2, according to the RFP, the contractor will evaluate whether peer supporters are part of the system. This should not be in question. Peer supporters must be trained and hired to be non-police crisis employees. The Substance Abuse and Mental Health Administration encourages this integration on mobile crisis teams, since people in crisis often lack trust in police, whose presence can be a negative trigger resulting in escalation. 3, according to the RFP, the contractor will develop a plan to connect 911 to 988. The non-police crisis system should be an integral part of a cohesive system of care that connects individuals to appropriate services, including all crisis lines. Connectivity includes the ability of 911 to transfer and receive other crisis lines, including warm handoffs, as well as the necessary protocols for transfer and cross-training of staff. Finally, the RFP requests that the contractor establish a temporary citizen advisory board to review the contractor's proposed plans. The RFP also asks the contractor to analyze the feasibility of having this board. Columbus Safety Collective has advocated for a permanent advisory board to develop, implement, and oversee operations. This board will seek and integrate community input on an ongoing basis about service availability and gaps. thus expanding community input into intricate policy development. Currently, most community members often only have 3 minutes at public hearings to address these policy concerns. Thank you for your time.
Thank you so much, Ms. Sweeney. As I heard it, your questions were around, one, first responders. If this, what we are building it to be first responders, the ability for us to hire folks as peer supporters, the integration of call taking, and the importance of the Community Advisory Board. Can I actually ask folks from Mission Critical to speak in terms, not of the scope, but at this early stage of assessment, how you think through those types of questions? Is that a thoughtful question? So understanding that Ms. Sweeney's questions were around us considering this, looking at first responders models, us understanding the importance of peer supports, us working to make sure that our initial intake calls are integrated, and lastly, I would just say the importance of the Community Advisory Board, just how you, as our outside external partner, help us think through those things. And what experience are you bringing from other communities that would advise us?
Yeah, I mean, from the perspective, again, as the scope of work, as part of the RFP, we committed to looking at each one of those elements, right? And I think it takes a combination of, as Ms. Sweeney being from the community and bringing those concerns, looking at the qualitative data, the quantitative data, having these conversations, and then looking at what else is happening out there already in the country, but then taking that information and determining what does that mean to the city of Columbus, can it be tailored, going back to that one size does not fit all approach, and making sure that however that comes together is something that can improve the services for the city of Columbus. Does that make sense?
Thank you.
You're very welcome.
Those are really good questions, Ms. Sweeney. So thank you for posing those. The next speaker to come for council is Channa Wiley. I apologize if I miss. Welcome to council. Is it Channa or Shan? I apologize.
It's Chana. It's okay.
I apologize.
Council President Hardin, Weish, Green, and Remy, thank you for having me and giving me the opportunity to speak today. I'm Chana Wiley, and I'm the co-chair of Columbus Safety Collective, a group of advocacy organizations, directly impacted families, and community leaders dedicated to creating a safer and more just Columbus for all residents. I was actually brought into this work through a tragedy, and now I'm trying to find solutions. I joined OFU PAC, where I'm the campaign manager, to help make policy change and ensure that the tragedy I experienced doesn't happen again. I joined Columbus Safety Collective as an advocate due to the unfortunate death of my brother, Jerron Thomas, by the hands of Columbus Police Department. He was in a mental health crisis and only needed help with transportation to a hospital for evaluation and stabilization for his crisis. He did not have a weapon, was not combative, and was excited to see that what he thought was help had arrived. He needed an ambulance to transfer him to the hospital, not the police to use excessive force and to treat him as a criminal and beat him to death. Jerron coded in the front yard due to him being beaten and kicked with a knee to his back while tied at the ankles and handcuffed. It was when the police noticed his body limp that they called the ambulance and had them try to revive my brother. This was considered a co-responder model, which failed to meet the needs of my brother, who suffered from schizophrenia. If Columbus Police had a non-police emergency response system to this type of call, my brother would be here today. This has caused a lot of issues in our family and community. I am still dealing with the effects of his death. My son and his daughters now suffer from mental health issues stemming from his death. There was no accountability from the city in our lawsuit. The issues continue to happen over and over again here in Columbus and across the country. We, as the Columbus Safety Collective and as community members, have been very clear with the city that we need a crisis response program that is available 24 hours a day, 7 days a week for residents of Columbus who are nonviolent and pose no threat to themselves or others. So many of our community members, including my brother, just need care and help in their times of need. I've spoken before you for years asking you to invest in a program that is part of the 911 dispatch, where crisis responders are the emergency personnel who respond to mental health calls. Investing in an alternative response program is an investment in community safety. Existing emergency services are not enough to meet the needs of residents, and in fact result in the loss of lives. The Columbus Safety Collective hoped our city council members had finally heard our urgent message when you allocated the $1.2 million for the alternate response program, but we have yet to see anything concrete beyond the plan and timeline for an evaluation of current programs. We, your constituents and residents of Columbus, deserve a fully funded alternative response program. We ask you to lead bravely, set aside political differences. Columbus offered a resounding endorsement of these services nearly 5 years ago when you reimagined public safety and your intent to reimagine it. We refuse to wait any longer for basic community care. Thank you for your time.
Thank you so much, Ms. Wiley, and I'm so sorry for your loss. One of the questions that actually we did not hit on much tonight was the 24-hour even coverage of support services. That's why when NetCare said that they were going to stand that up, that is a big deal for me, that we would have that coverage. It's something that I really do want to ask Mission Critical about how they will advise us to get there. But what I was saying in general is we look forward to working with you, and your advocacy is not going on deaf ears.
Thank you.
Thank you, Ms. Wiley. Next speaker to come before council is Ramona Obi. Welcome back to council.
Hello, council. It's been a minute. Oof. I do want to also shout out the current teams that have been working with you guys as well. What Children's Hospital is doing, I think, is fantastic. But coming back to what Ms. Chana just said regarding the Columbus Safety Collective, which is an organization that has been around since 2020, off the height of the George Floyd rebellion, there has been a lackluster of support towards the organization, and it has moved almost in the direct opposite way in which the Columbus Safety Collective has tried to guide these non-policing response programs. For me, which I don't have a lot, but I'm wondering, how are we going to be more proactive in our responses going forward instead of so reactive? The reactive responses going off of mental health, of course, is needed and is much so very necessary. But in a private meeting months ago in which the Columbus Safety Collective participated in, I participated in, as well as other community organizations, I shared some proactive plans that I felt the city of Columbus could also start moving towards rather than waiting for these crises to appear. Communication after those proactive plans were shared was cut. Even though I felt like I got really good support from you guys when it came to those proactive plans. And I'm wondering if we're doing anything to move towards that style of programming going forward, as well as community input. Again, I love the teams behind me. I know it's a hell of a job to do that style of work, but without the community support and community input, are we really meeting the community with what is needed? And right now, it seems like such a barrier for the communities to actually take part in any of these programs. I hear what Mission Critical is doing, which I think, again, wonderful. Get the information needed, survey the community, do everything you have to do. But am I supposed to go to a website and sign up Am I waiting for them to come to my neighborhood and I'll just see a flyer at a library? Whose community are they coming to? How do they plan on meeting with the most impacted communities? These are some of the questions that come up for me as somebody who would love to take part in that style of advocacy and making sure that the communities that are most impacted are the most heard from. So thank you guys very much.
Thank you, Ramon. That was really the question you, Councilmember Weiss, was asking to Mission Critical. How are we getting to this level of advocate and community activist and leader on this issue? I would just encourage, even before the evening's over, to get with Ramon. But go ahead, please.
So Jen and I were back there, okay, we have, so the Community Safety Collective meeting that we said we already have, we actually know Ms. Sweeney, you're already on there, and so is Chana.
Okay.
So they're already, that meeting, I believe, is Tuesday. It's
Cool.
a couple hours long. We're already communicating, saying it probably needs to be longer. Are we gonna, make another trip up here to make sure that we have more time with some of these folks? But now we have more names behind the groups and those types of things that we're gonna be able to have a more direct reach out. But we're very happy to hear that those names are already on our list, but Ramon, we'll have to make sure we get with that as well.
For sure. Appreciate you. Thank you. Thank you for that feedback. I also want to follow up, Ramon, too, on what was given to was it my office? All right. I will follow up with my team. Next speaker is Ms. Rebecca Duran. Welcome back to council.
Thank you for allowing me to speak. I come both in professional and personal. In my professional, I heard someone specifically mention about SDOH, which is social determinants of health, but I did not hear anyone mention anything about using community health workers in addition to social work. I work for Nationwide Children's Hospital. I don't represent them, but I'm a community health worker at Nationwide Children's Hospital. And the way that we work together, they handle what I call heavy hitters, things like suicide, domestic violence, things like that. We end up handling connection to resources and things like that. Of course, that can vary depending on how the partnership works, but that's something I strongly suggest that be worked into that plan. It would be another way to increase the amount of people that are on the team and not necessarily police response. My personal view on this, I did learn a lot tonight about like the 24 hours. One of my comments that I had made was that it needs to be 24 hours, not just, I said 9 to 5. The other thing is that when it comes to my son Donovan Lewis, who was murdered by Columbus police, there is on record multiple times of me saying to police officers in different situations, he needs mental health help. I don't want you to kill him. The last time I said that, 20 days later, he was murdered by a Columbus police officer. So this type of response is necessary. It may or may not saved him. I believe he was in a manic state at the time that he was murdered when he did not answer the door. People who have experience with mental health disorders, there are times when they are in certain like down times that they sleep for an exorbitant amount of time, getting up maybe only to go to the restroom, and they're not coherent in those time frames. So, and then they go back to sleep. You know, I made a connection like to hibernation. Like they're not functioning in that downtime. That being said, that one could hope that may have saved my son if someone like an alternative response was present at the time. I feel like when police respond to many things, it's a response of escalation and annihilation, unfortunately. What we need is de-escalation and protection of both parties, both the officers and the people who are there to serve. I've said it before and I'll say it again. I'm not 100% against police, but I'm against how they are currently operating and the fact that that CIT training needs to be provided to all police officers because they all respond to people with mental health crisis at one point or another, even if it's not the alternative response.
Thank you so much, Ms. Rebecca, for being here. Over the years, we've engaged, and your strength is we don't know where it comes from, but we appreciate what your advocacy and your continual push to provide more services to our community. So just thank you.
May I ask one question? real quick?
Please.
Is Gates no longer with your office?
He's not.
Okay, well then, if it's possible, I'd like to reach out to your office. Who would that be?
100%. John, oh, well, this is my aide right here,
Okay.
but I want you to connect with Tanus in the back. He's sitting in the far back.
Okay.
Please, I would like to, yeah.
Okay, thank you.
Thank you.
Thank you.
The next speaker to come before council is Dr. Bevis. Welcome to council.
Good evening, President Hardin, council members. Thanks for your guys' time. My name is Leah Bevis, and I'm a professor of applied economics at Ohio State University and a Columbus Safety Collective member, funded by the Robert Wood Johnson Foundation. A colleague and I recently evaluated the MCR program and Columbus CIT training. I've actually reached out to set up briefings for you on that, but that's not what I'm going to talk about right now in these 3 minutes. In the last 6 months, I've spoken with public servants in cities across the Ohio and the U.S. Who have been instrumental in standing up non-police crisis response teams in their own cities. And I want to give council a feeling for what those timelines looked like in other cities. Durham began by hosting a roundtable with city agencies, fire, police, and others, and a series of community conversations to get community input on crisis response. Within 1 year, they launched a call diversion program, like Right Response, a co-response program, like MCR, a non-police crisis response program, and a follow-up care navigation program, all under their larger HEART program. They started 23 staff and 17 first responders and expanded quickly. Though initially opposed to the program, Durham police quickly came to see that the HEART program was useful. They were drawing away calls that police didn't then have to respond to. So now the program has a great relationship with Durham police. Dayton began by launching a non-police response program for low acuity calls that did not include mental health problems at the beginning. Those were initially deemed as too risky. Staffed by the existing mediation center, the mediation teams primarily address community conflicts. But over time, the mediation teams began handling a wider and wider array of calls, including behavioral health calls, because they just seemed so capable. Though initially hesitant, Dayton police grew supportive as they observed that the mediation teams didn't tend to require assistance and were diverting unwanted calls. Today, Dayton police actively refer calls to the non-police response program, and the two programs have a really excellent working relationship. Albuquerque's ACS program was piloted rapidly after a period of extensive community input. City officials stressed that community input gave them everything from the clothes that they wear to the vehicles that they drive. They also consulted with Durham's HEART program during that planning period. Initially, ACS deployed 5 non-police teams for behavioral health calls, complementing the city's existing co-response teams. Over time, lower acuity calls were assigned to a new set of community responder teams. ACS has since added street outreach teams for homelessness and integrated a pre-existing violence interrupter program, all under its umbrella. These cities started around or after Columbus launched its Reimagining Public Safety campaign. They engaged stakeholders, consulted communities, learned from other existing non-police response programs, no need to reinvent the wheel, and piloted small initiatives within a year or two. Then they scaled up. Yet in Columbus, in 2025, 1/3 of your 2023 allocated alternative crisis response program is now spent on a consultant group. From my work with the CPT CAD data, I can tell you that only 5% of behavioral health calls, and 8% of mental health and suicide calls are handled by the MCR team right now in the last 2 years. Meanwhile, there's still no non-police crisis response program, and multiple lives have been lost in the last couple years that such a program might have saved. So my question to council is, why are we so behind these other cities? What does this current process say about council priorities and council political leverage? And what should Columbus residents think about the fact that this process is ongoing? You know, should they trust that you're still committed to standing up a non-police crisis response program to enhance the safety of our communities? Thank you.
Thank you so much. Are we behind other communities? I know that I've talked to several folks that are sitting in front of me, and they are aware of Albuquerque. They are certainly aware of Dayton. I'm not familiar with Durham, but I'm sure that some of the folks in front of me are. Are we behind? Like, how would we self-assess before we get the assessment from Mission Critical? I think it's a fair question, truthfully. I'm not asking for anybody to stick their neck out there, but I think that it is a fair question to ask. And I will say that council has been clear about the direction that we have been encouraging and working with the administration to go on. We have been extremely clear about where we see the need and where we would like to get to. Anybody want to take a shot at? Because I think that, and I'm not trying to lead a question, but I think that we are doing some things very well. The parts that we want to do, we're doing very well. How are we, when somebody want to take a shot at, how do we see ourselves compared to our peers? That's a good question. How do we see ourselves compared to our peers?
Thank you, President Harden. From my viewpoint, there are certain things that we are very strong at and we do very well, and there are other things that we need help and assistance to get to that point. And if we look back at historically the teams that we do have stood up and what we presented on tonight, each one of those things, and I think some comments were made, were issues that have come to public safety, that the Department of Public Health and that other individuals, I apologize, that issues that have come to public safety, be it the Division of Fire, Division of Police, or to public health, where there's been innovative solutions within those individuals who are front-facing to deal with those. But there are opportunities and there are areas that we need help. And we hope that Mission Critical Partners will help us do that. I can't say that I'm personally familiar with Durham's setup, but I certainly would love to learn as much as I could about that.
Appreciate you. Only point I would make is having the community closer to what we have been doing, I think is one of the things that I think we can learn from. Because I think that, like I said, I think that every time we have these hearings and we talk about what we are doing, everybody knows what we're not doing. We're not yet at a non-police pilot yet. We are not there. But the stuff that we are doing, I think, is fantastic. We're not doing enough of it. We're not directing enough resources to it yet. But I don't think that because we don't engage, we don't put proximity between us and the community, it allows for misunderstanding of even what we're doing. And so I would just acknowledge that that is one of the opportunities as we move forward. Sure.
Doctor, I just want to also sort of share a little bit of my perspective based on your testimony. A lot of the parts and pieces that you pulled out are things we are already doing here in Columbus. We have street outreach. We have non-police response. There are programs and our partnerships with Nationwide Children's Hospital and NetCare Access. We have co-responder models. I used to work with one very closely, and that one didn't involve police. It just involved me, a social worker, and fire at the time. I think what we are facing at this moment is this crisis response field has changed rapidly in a very short amount of time, with a focus on it at the state level that guides policy and a focus on it at the federal level that sets standards and expectations. So as we are trying to build a new program that's integrated, that's taking all of the good work that we are doing and weaving it all together to not reinvent the wheel or disrupt systems, we essentially are living in a house already and we can't tear it down because there's people inside of it. We have to sort of take out brick by brick and figure figure out how do we weave everything together, these parts and pieces of all this good work that we're doing, and conform with the changing standards around us, which becomes a little bit tricky from a policy standpoint and then from a program standpoint, and how that actually impacts from a programmatic standpoint. And so one thing that I will say, just even by having this hearing, by bringing in Mission Critical, helping us understand the landscape of the state and federal policy and regulation, the opportunities for funding so that we can really scale this. So we're not just piloting a program, but we're really providing real to scale interventions to our community that are appropriate and to their expectations. I think that is where we will find the greatest strength in having that external partner that can help guide us through that while we continue to do the great work day in and day out of A, providing those responses in the community, and B, also figuring out how, in the absence of the larger big plan, how do we continue getting a little bit better every single day, working together and collaborating and integrating on our own while we're developing that plan. That's my lens, I guess. That's my opinion. That's Melissa Green's opinion, not Councilmember Melissa Green. But.
Awesome, they have it. It's important to note that that program does not exist for 911 calls. You will not get a non-police response program if you call 911.
I appreciate you, and seriously, I do appreciate you, and you know that we've been in meeting. I think that part of the reason why we are here today is because of the advocacy of our community. So I'm grateful for the question and the push, and I'm grateful for my colleague who, again, I'm grateful for your leadership. The last speaker to come for council is Brianna Chambers. Brianna, welcome back to council.
Hi, my name is Brianna from People's Justice Project. For my testimony, I will be advocating on behalf of Ricardo Flores. When talking to Margaret, a friend of Ricardo's, and who told me this story, she emphasized how brilliant Ricardo is. He is a veteran, college grad, and just overall a great person. Ricardo unfortunately suffers from bipolar disorder. While experiencing a mental health crisis where he was unresponsive standing at a neighbor's door, Margaret called the mobile crisis unit, and police officers were dispatched. Margaret was informed to call this unit by NetCare, an organization that was helping Margaret with Ricardo's mental illness. Ricardo was unresponsive because he was having a mental health crisis, and one thing led to another, and a police officer came to Margaret and explained that they had the option to send Ricardo to the hospital or to jail. And Margaret, someone who understands that people with mental illness should not be criminalized, told them to send Ricardo to the hospital. But police officers decided to send Ricardo to jail. Ricardo spent months in jail not receiving any form of treatment, and because of this, he was unable to advocate for himself in court. Now Ricardo is at Twin Valley, and from what Margaret has told me, Ricardo is not getting the help that he needs. He doesn't even know why he's there. This situation happened in April. It has been 9 months. You can probably guess, Ricardo is Black. Black people we know are disproportionately impacted by mass criminalization. People can function and live a good life with bipolar disorder, but because police decided Ricardo's life does not matter, he can't get the help that he needs and is thrown into the system. I'm starting with this story to emphasize that an alternative crisis response has to be non-carceral, that it should not include CPD or the supervision of the public safety. They can't even stop their police officers from killing people, or in this case, locking people up who struggle with mental illness. It's not that we are not seeing what you are doing. It's that you haven't done anything and let CPD terrorize the communities. And you know the numbers. I hope that this is not a plot to keep public safety overfunded and leaving other things underfunded. You had organizations this Tuesday that help unhoused folks begging for money. But you are willing to give a violent police department close to $400 million every year. And are not gonna make any legislation or do anything to prevent police from being brutalized by police. You guys are apparently have been okay with a system that negatively impacts people, especially people that look like 2 of the city council members in this room. It is disgusting, and this should have happened a long time ago. Thank you.
Thank you, Ms. Chambers. With that, thank you all for being here. This is a critically important conversation. We see and understand how intricate it is. I want to thank the administration, to our folks in public safety, public health, for the work that you're doing. For our community partners, we're extremely grateful for the collaboration, for mission critical. Thank you so much to our Division of Police, Division of Fire. Matt, seriously, thank you for your leadership. And we have work to do. So thank you all for coming out.